Uh, all right then. Good evening, everyone, and so welcome back to a series of clinical classes organized by PeMSAA. I'm glad we have Prof. Kudagamana also with us because he's spearheading this initiative, and it's due to his vision that we have this program going today. So I'm very grateful to him as well. Today we have Dr. Harsha Ariyarathne, who will be speaking on some orthopedic clinical scenarios that the students have requested and are commonly seen in surgical practice. Before I introduce Harsha, a few ground rules. Please keep all your mics on mute through the session. Dr. Harsha will be talking about 3 separate clinical scenarios, and at the end of each scenario, there will be a few minutes allowed for questions, say about 5 minutes of questions. If you have questions during the session, just type them in on the chat. We'll field the questions and we'll deal with each area at the end of that particular section. Going on to Harsha, Dr. Harsha Ariyarathne is an alumnus from the class of 97 and 98. He had a brilliant undergraduate as well as a postgraduate career, which culminated with him getting the gold medal in the Orthopaedics Part 2 examination, and he qualified as a consultant orthopedic surgeon. He worked for a while as an acting consultant at Peradini Hospital, and then he was consultant orthopedic surgeon at Hambantota Hospital. In 2019, we lost a very good teacher to the government sector because Harsha, for personal reasons, decided to work full-time in the private sector. So he's now the on-call consultant at RCD Hospitals, Kandy, in orthopedic surgery. Harsha has been a teacher to me as well as many trainees in postgraduate surgery as well as undergraduates for many years now, and we used to enjoy as well as look forward to his classes in orthopedic surgery from the time that we were students and also when we were postgraduates. So I'm sure you'll enjoy today's talk. So thank you again, Harsha, for accepting the invitation, and over to you to start the presentation.
Right. Thank you, Buddhika. Thank you for those kind words. First of all, one of the main regrets I had of leaving the government sector was not having a chance to teach. So I'd like to thank PeMSAA for giving me this opportunity. So today's talk is not going to be a comprehensive lecture about the topics we're going to talk about. What we're going to do is we're going to discuss what needs to be done in a ward setting. So if you want to have a complete knowledge of what's happening, it's all available in textbooks. So there's no point for me to come in and completely give a textbook description of what's happening. So we'll be discussing 3 common areas which you see either mainly in a surgical casualty kind of scenario setup, and these are things that you'll also be tested at exams. But this talk is not geared at an exam setting. It's more a ward setting, how to work in a ward, what kind of things you need to do. So we'll just take each of these scenarios one by one as it comes. So, okay. So straight off, the first scenario will seem quite familiar to you. So we are talking about a 8-year-old girl who's fallen from a swing fairly recently and is brought into your ward, and she complains of pain in her right elbow. As you can see, there's a visible swelling, there's some deformity, and this child completely refuses to move this elbow. And on further examination and inquiry, you find that there is no other apparent injury. Now here you are with a child having a fall with a painful, swollen, deformed elbow. Now you got to have a possible differential diagnosis running in your mind. So of the possible differential diagnosis, you have to have one particular one at the back of your mind telling you, all right, if it's this, expect trouble. So this is one of those injuries where you can expect to have lots of trouble. So what could it be? Of course, you know about the supracondylar fractures of humerus, lateral condyle fractures of the humerus, olecranon fractures, yes. You can have proximal radius and ulnar fractures, of course. And very, very rarely, you can have a dislocation of the elbow in an 8-year-old. Very rarely. I've seen 2 cases where I have been one of them. So it's very, very rare. But of this list of injuries, of this list of skeletal injuries, only one is fraught with dreaded acute complications. And you know what that is. We are worried about supracondylar fractures of the humerus. Okay. Now this child is in front of you, has this swollen, deformed elbow, right? So you've got a list of differential diagnosis. So you arrive at a definitive diagnosis by doing an X-ray. So before you send the child for an X-ray, you have to have at the back of your mind, is this a bad supracondylar fracture? So before you let the child go for an X-ray, you got to do a couple of things. Okay, I'm just showing this X-ray to show you what a bad supracondylar fracture looks like. Now, what you see here, of course, is the humerus, the radius and the ulna, and the broken part of the distal humerus. This is what you see on the X-ray. The problem arises from what you don't see on the X-ray. Namely, the brachial artery will be draped across this jagged edge here along with the median nerve. The radial nerve will also be stretched. Your ulnar nerve will be also stretched. And you can also see the venous drainage of this the arm area, the forearm area would also be compromised because of the deformity. So now you got this child. All right, now we are going back to what you have on your hand. You have a child with a swollen, deformed elbow. Before you send the child for an X-ray, you've got to do 3 things. You've got to assume for the worst. That means you've got to assume the child has a bad supracondylar fracture, and you've got to examine the child's vascular status or the perfusion status of that limb. All right. So for functional purposes, the vascularity of that limb can be categorized into 3 main areas. First one is what we call a pink limb with pulse, where you have the hand is pink, it's warm, it's perfused, and the distal pulse is palpable. Okay, so this is the best of the 3 scenarios. But even a pink hand with pulse needs to be monitored continuously. The second group, the hand is pink, but you can't feel a distal radial pulse. So these are called pink pulseless hands. So what's happened here is the brachial artery is now compressed, but circulation is maintained by the collaterals around the elbow. If you hark back to your knowledge in anatomy, you know that you have a lot of collaterals around the elbow, which can perfuse the hand even if the brachial artery is completely compressed. These need urgent intervention in that the fracture needs to be reduced to try to get the brachial artery back in the proper position so that there will be proper circulation to the distal arm. So they need to go to theatre immediately for immediate reduction. Next group is a pale pulseless limb. Now this is a dire emergency. There's no time for mucking around. You are dealing with an acute ischemic limb. This is one of the problems in this fracture. So you need to inform your seniors immediately when this, even the pink pulseless hand, you have to immediately inform your seniors, but the pale pulseless limb is where the hand is white, it's pale, it's cold, and there's no pulse. You've got to inform your seniors and you have to arrange for a vascular consult step. Now, if you're in a hospital without orthopedic cover or without a vascular surgical cover, you need to decide what you're going to do with this patient. Say, for example, you're in a remote area like, say, Tissa Maharama, which does not have an orthopedic surgeon, nor does it have a vascular surgeon. The adjoining hospital has an orthopedic surgeon, but does not have a vascular surgeon. So you have to make a decision as to where you're going to send this child. You have to send this child to a place which has orthopedic and vascular services on tap all day long. Okay. So this is something that you need to, and you have to document all this. The next thing that you've got to examine in this child before sending for the before sending for the X-ray, does this child have a compartment syndrome? Now, when you talk of compartment syndrome, the most important thing to diagnose a compartment syndrome is awareness. You have to know what parts of the body can have a compartment syndrome. So you know that. So the forearm, the leg, the hand, and the foot are common places where you get compartment syndrome. So clinical suspicion is the most important thing when it comes to diagnosing compartment syndrome. What do you do? So how do you diagnose compartment syndrome? This bit is very important. There is just one symptom and then there's just one sign to diagnose compartment syndrome. Nothing else. One symptom, one sign. The symptom is severe intractable pain. The pain is out of proportion to the perceived injury, and the pain does not respond in any means to simple analgesics. That is a symptom. The only sign which is important is severe pain when the muscle groups are stretched passively. For example, if the forearm flexor compartment has a compartment syndrome, passive extension of the fingers will cause stretching of these muscles, and that stretching will cause severe pain. All right. So those are the only two things that you look for to diagnose a compartment syndrome. Now I'm telling you this right now at an exam setting. If somebody asks you about compartment syndrome and you talk about distal pulse, distal capillary refill, compartment syndrome and arterial perfusion have nothing in common. It has nothing to do with compartment syndrome. And it may even actually cause you to fail the exam if you mention distal pulse when you're talking about compartment syndrome. Okay, let's talk about this child. This child maybe has a systolic blood pressure of 100 millimeters mercury. For the distal pulse to disappear, you need a pressure in excess of 100 millimeters mercury to occlude the artery, correct? But you got to remember, in compartment syndrome, what happens is the muscles and the nerves start losing oxygen, start losing nutrients for their usual metabolism. Now you have to remember, the oxygen and the glucose does not come directly from the artery. It comes from a diffusing surface, that is your capillaries. And if you remember your physiology, the mean hydrostatic intracapillary pressure is 28 millimeters mercury, not 100 millimeters mercury. So all the compartment pressure has to exceed is your hydrostatic pressure inside the capillary. That's 28 millimeters mercury. So this is same for the entire body. So if you say that the pulse is present and therefore there is no compartment syndrome, you've missed the bus. Okay? So two things, one symptom, one sign to diagnose compartment syndrome. Also, there is a test which is not freely available where you can actually physically measure the intracompartment pressure. I'm not talking about that because that is not freely available. So the treatment of compartment syndrome is an urgent fasciotomy. Now, I put some asterisks here because when I say fasciotomy, you don't do fasciotomies on every compartment syndrome that you get. I'll tell you why. Timing is of key. If you get a patient 24 to 48 hours after the onset of the compartment syndrome, By the time you get the patient, all the muscles and the nerves inside the compartment are dead. Okay? So if you do a fasciotomy in such a patient, you'll be opening up that dead tissue to all the microorganisms around in the environment, leading to severe infection. Also, you'll also be reperfusing the limb, and you'll have a reperfusion injury which could threaten not only the limb but also the life. So generally, compartment syndrome, if you get the child before 12 hours of the onset of the pain, severe pain, then you must do a compartment syndrome. There is not much evidence to say that there's a benefit to do a fasciotomy after 12 hours. So it's very important that you got to do this very early. Next thing you got to look for is the neurology. Now, remember the X-ray, remember the structures that can get damaged. The commonest injured nerve is the anterior interosseous nerve, which is a branch of the median nerve. Also, you can get a dense median nerve injury, ulnar nerve, and also sometimes, rarely, you can get a radial nerve injury. So you got to examine this. So the easiest way to examine all these nerves in a matter of seconds is to play a game the Western kids play called rock, paper, scissors. When they say rock, you tell the patient to make a fist like this. When asked to make a fist like this, if there's a median nerve injury, the patient won't be able to make a proper fist, and you'll have this pointing finger sign which signifies a median nerve injury. Okay, so rock, you make a fist. If there's a problem with that, if there's a problem with the median nerve, with the rock movement, you'll have this pointing finger which signifies a median nerve injury. Then you say paper. Paper is where you have a straight wrist, straight fingers. So for this to happen, you have to be able to extend your wrist, and you have to be able to extend your metacarpophalangeal joints. So that means your radial nerve is intact, therefore you can extend your wrist. You can extend your metacarpophalangeal joints, therefore your posterior interosseous nerve is intact. So rock, median nerve, paper, you're checking your radial nerve as well as your posterior interosseous nerve, and scissors. You ask the patient to do this. That's checking your interossei, which are supplied by the ulnar nerve. So rock, paper, scissors. In 5 seconds, you've checked all the nerves. And the last one, you say, make an OK sign. If the child can do this, you know the anterior interosseous nerve is intact. So rock, paper, scissors, OK, your nerves are done. Okay. Most importantly, document, document, and document. This kind of injury can cause the patient to lose a limb, and it can cause your boss to lose his job. So this is in your hands as an intern, is very important. Okay. I hope that's clear. Right. Now you have the child, you've examined, you've checked for vascularity, you've checked for compartment syndrome, you've checked for the neurological status of the limb. Now it's time to get the X-ray. So you leave this until you've done your clinical examination. So you splint the limb in the position the child comes in. Usually the child comes in with an extended elbow. You don't put it into flexion and put a plaster. You splint the elbow in the position the child presents. Okay, and it's usually a posterior splint with ample amount of padding, and especially when you wrap it with a bandage, you make sure there are no constrictions around the elbow. That's very important. Okay, and once you've splintered, you can give some analgesics and you send for the X-ray only then. Okay, and while the child is on the way to the X-rays, you can inform your senior saying, all right, there is a possible supracondylar fracture which may need to go to theater. So you have to inform your seniors and you have to inform the theater. Okay, and prep the child for theater. Make sure that child's kept nil by mouth, because reflexly Sri Lankans tend to feed their children the moment they get injured. So you make sure that people accompanying the child is told not to give the child anything by mouth. All right. Okay. Now these two X-rays are put for nothing else, just to show the mechanisms of how you can have a supracondylar fracture. Now, the commonest mechanism is where the child falls on an outstretched hand like that. So fall on outstretched hand, it's conveniently abbreviated as a foosh. We call it a foosh injury. And here you get what we call an extension type of injury. The fractured part is displaced dorsally. And that's the most common. In fact, it can be up to 98% of all the supracondylars you see. The second type, the rarer type, is where the child falls on the point of the elbow, causing what we call a flexion type injury. So I've mentioned this because once you see the X-ray, this holds bearing on how you immobilize the immobilize the limb. In an extended type of injury, you understand that the elbow is unstable in extension. Therefore, it has to be immobilized in about 90 degrees of flexion. You don't go above 90 because that's going to further occlude, further impinge your vessels in front of here. So extension type injuries have to be immobilized in flexion if you're managing conservatively. And flexion type injuries, if you try to put a flexion type injury into flexion, you're going to displace the fracture even more. Therefore, flexion type injuries have to be immobilized in a little bit of extension, maybe 120 degrees of extension. Okay, I put these slides just to tell you about the different ways in you immobilize the limb depending on what type of fracture you have on hand. I hope that's clear. Right. On the other extreme, you have a child who has fallen, has elbow pain, and on the X-ray, you can't see a fracture. Child still refuses to move the elbow, but there are indirect signs that can tell you that there is a possible fracture in the region. Now, if you look at this, just behind the posterior cortex, you see a dark shadow where this red arrow is pointing. You call that a posterior fat pad sign. Okay, and here anteriorly, you have this dark shadow, a triangular sail-shaped shadow, which you call a sail sign. What this signifies is that there is an occult fracture around the elbow, which most commonly is an undisplaced occult supracondylar fracture. So all these requires just immobilization. That's it. It does not need anything else. And of course, observation of the limb. So this is something that you may miss if you don't look for it. You say, all right, there's no fracture and send the patient off. Whereas there's a crack, child goes home, knocks the elbow, and now this undisplaced fracture can become displaced. Hope that's understood. All right. I promise that there'll not be too much detail, but I had to put this because this is something that may be asked at during your Viva about a classification system for your supracondylar fractures. There is a classification system called the Gartland classification. Originally, the Gartland classification was only from type 1 to type 3, where type 1, as you can see, is undisplaced. Type 2, you have disruption of the anterior cortex, but the posterior cortex and the posterior periosteum remains intact. Whereas a third, type 3, you got a complete displacement with complete rupture of the both cortices. Later on, we found that there is another type of fracture which we call type 4, which is unstable in all directions. It's unstable in flexion as well as extension because the periosteum is also gone. So it's just flapping around, and these fractures are very, very unstable. Okay. So this is important when you come to management. So this is undisplaced. All this requires is splintage. That's all. Okay. So type 2, this requires some form of reduction and splintage because these are inherently stable. This is also fairly stable, but they can tend to drift into a poor position after manipulation. So these two types require some form of stabilization. Okay. Right. So management, as I said, depends on degree of displacement. So undisplaced ones, you splint. And the displaced but stable, the type 2s, can have a close reduction. You take the child to theater under anesthesia, do a manipulation, get it into a good position, and place them in a posterior splint. You don't put them in a full cast because you can have a tight plaster with disastrous results. Okay, then you've got your displaced and unstable fractures which require close reduction and some form of pin fixation. Now you notice that these pins are placed from the lateral side to fix the fracture. You don't stick pins from the medial side because that's where your ulnar nerve runs. You can otherwise skewer. You can do a fixation of the ulnar nerve to the humerus. Okay, so this is your standard. This is your standard protocol for managing supracondylar fractures. Sometimes in type 4 fractures, it is very difficult to get a close reduction, in which case you might have to do a open reduction and a pin fixation. Okay, so that's the first part done. It's a very common it's a very common thing you see during your surgical rotations. So if there are any questions pertaining to supracondylar fractures that you'd like to discuss, I think now would be the time to do it.
Thank you, Harsha. We have two questions so far. One is, what is the management in compartment syndrome after 24 hours?
All right. Okay, so the question is, what do you do after 24 hours after the onset or after establishment of compartment syndrome? The consensus is you don't do a fasciotomy, you leave it alone. It's better to have a Volkmann's contracture, that is a sequelae of a compartment syndrome, rather than a pus oozing infected wound, which is hardly ever going to get better. Okay, so it's a trade-off. Unfortunately, you're not going to get an excellent result. You choose the lesser of the two evils. You tend to accept a Volkmann's contracture rather than a possible amputation or possible dead child. Is that clear?
And like you mentioned earlier, I think documentation is also very...
Absolutely. There are currently a couple of cases pending in the legal system in the country where the consultant is now almost being, it's come to a point where all the blame is going to go on the consultant because purely of no proper documentation of what's happened. So it's very, very important. That's the job of the intern. Yeah.
Thanks. Next question is, I think you actually answered this immediately afterwards, Harsha. The question is, why do we splint in presenting position instead of trying to reduce to original position?
Sure. I'll just go back to this X-ray. Now, this is an extension type of injury. You all can see this, right? So yeah. This is where your brachial artery lies. So you would expect the brachial artery to go between go like that. It does not go like that. It goes in like that, takes a bend around that because remember it's plastered, and then it goes here. This is where the brachial artery divides at the level of the radial head. This is where it divides into your radial and ulnar arteries. So just imagine trying to force this back in. The chance of you catching the artery and the nerve within the fracture site is quite high. Okay. So if you just try to flex this, the chances of you pinching the artery in this is quite high. So if the child's distal circulation is fine with this X-ray in the existing position, common sense should dictate the arm should be positioned in this position, immobilized in this particular position. One more thing, there is a common misconception that if you think that there's a compartment syndrome, the arm should be elevated. That is not true. If you suspect compartment syndrome, you keep the arm at the level of the heart. You don't elevate it because you don't want heart to beat against gravity to at least perfuse what can be perfused. It is counterintuitive, I know, but if you think it's compartment syndrome, lay the arm flat in the level of the heart.
Great. I think you answered another question which has been asked. That exact question had been asked later. Then next question is there a place for K-wire fixation in a displaced supracondylar fracture?
Okay, so these are K-wires. K-wires are stainless steel wires, very rigid stainless steel wires. And what you see here are K-wires. K-wire stands for Kirschner wires. So this is exactly what they are. So we use K-wires in children. You don't want to go for fancy plates and screws. because remember, you're dealing with an area with a lot of growth plates. Screws and large implants and large screws can damage the growth plate, which can have growth deformities later on. So you're correct. We use smooth stainless steel pins, which are commonly called K-wires. Yeah.
Okay, great. Could you please explain again the position in which elbow is immobilized in fall on outstretched hand and fall on point of elbow?
Sure. Right. Extension type injury. So this is where the child has fallen on an extended arm. So this fracture part has been displaced dorsally, posteriorly. If you extend this limb, if this particular limb is extended, this deformity will be exaggerated. Is that understood? You're pushing towards the side of instability. This fracture is unstable in extension. You extend it, the deformity is going to get more. Therefore, in these kind of injuries, if you are managing it conservatively, I'm talking about a type 2, a Gartland type 2, let me go back. You're talking about a Gartland type 2 extension fracture. If you try to extend this gap is going to open up. Okay, that's what I mean. Extension type injuries should be immobilized in flexion, where this gap will tend to close rather than open. The converse is true. Sorry. The converse is true for flexion type injuries. If you try to flex this piece is going to get further displaced. Therefore, flexion type injuries, again, type 2, where the anterior cortex is intact, you want to extend the limb so that this is pushed that way and the fracture is held in a more stable position. Is that clear?
Great. Thanks, Harsha. Next question is, I think the next question is radial nerve damage more common in
It's the least common.
radial nerve condyle? Okay, so it's less common, no?
So the commonest nerve injury, I know it appears in one of your MCQs. The commonest nerve injury is the anterior interosseous nerve, a branch of the median nerve. That's why you check for the OK sign. You got to document that. Then your median nerve, then your ulnar nerve, then your radial nerve.
Great. When the supracondylar fracture is intra-articular, is it essential to go for open reduction and internal fixation?
Supracondylar fractures by definition are extra-articular. Okay. So intra-articular fractures of the distal humerus, the commonest one is a lateral condyle fracture. It's a completely different kettle of fish. Okay. It is unlike the supracondylar fracture. It is not an absolute emergency. So supracondylar fractures by definition are extra-articular. Lateral condyle fractures are intra-articular. They are managed completely differently. They're completely different entities.
The next question is really related to supracondylar, so I'll leave that for the very end if we have time.
Sure.
In case of suspected nerve damage, how is the management different?
All right. Most of the time, almost all of the time, they are neuropraxias. Okay. Even though you document a nerve injury, you do not go digging in looking for the nerve to repair it. These are most commonly neuropraxias which improve with time. So in this kind of situation, all you need to do is reduce the fracture and stabilize it, and then gradually go for physiotherapy. You do not go for nerve explorations in the acute setting. No.
Next one is if a patient presents after 48 hours with paresthesia and inability to extend fingers after a supracondylar fracture, that is presenting after 48 hours with paresthesia and inability to extend fingers, what would be the most likely diagnosis and how do we manage him?
Okay, so what you need to understand is paresthesia could be, if it's just paresthesia, it could be neurological, but you have to, again, basic pillars of medicine, examine history. The question is, you fell 48 hours ago. When did this paresthesia happen? Did it happen in the last 5 hours? Did it happen last immediately after the fall? How is it progressing? Is it getting worse, getting better? So those are situations where you have to actually play it by ear. You may be dealing with a compartment syndrome which is developing late, in which case you need a fasciotomy, or you may be dealing with already established delayed presented compartment syndrome, which unfortunately you're going to have to observe. If it's neurological, you're not going to do anything about it. You just need to manage the supracondylar fracture. So I think your question is again delayed presentation of a compartment syndrome. So delayed management of compartment syndrome is leave it alone. Fix the fracture. Don't go looking for nerves. Nerves should take care of themselves. If they don't take care of themselves, later on we can think about nerve transfers, tendon transfers. There are procedures. There are things that can be done at a later point.
Okay, thanks. Then there's another question on, how do we manage pain in compartment syndrome if the patient presents after 12 hours?
All right. So after 12 hours, your patient presents. Now again, 12 hours is not the time from where the fracture happened. 12 hours is the time from when the compartment syndrome set in. Okay. So if we're talking about after 12 hours from when the compartment syndrome has set up, then of course you'll be looking at opioids, that kind of thing. Of course, paracetamol, and you'll be using your ladder, but more often than not, you might end up using opioids. Okay.
Great. Then there's a question on whether you could explain compartment syndrome again. If we have time, we'll go back to that at the end, isn't it?
Sure. Okay.
Then what is intercondylar fracture? That's another question.
Okay. So, okay. Unfortunate. Okay. So your distal humerus has two condyles, your lateral condyle and your medial condyle. Okay. So common sense you dictate the fracture line would be straight down, a vertical fracture line. It is not very common in children. It's actually fairly common in adults, where you get a vertical split of the medial and lateral condyles where the distal condyles part ways. So that is an intercondyle fracture. Technically, a lateral condyle fracture is also a type of intercondyle fracture. Unfortunately, I don't have an X-ray of the lateral condyle. So you have the fracture line between the lateral and the medial condyles of the distal humerus. So that's an intercondyle fracture.
Then next question is, if the fingers are cold in a supracondylar fracture and the saturation is low, what's the initial management? I think
all right.
Describe that.
Okay, initial management is now again depends on where you are. If you are in, say, a base hospital where there's a general surgeon, okay, it's again common sense. You need to get this child to a place with orthopedic cover as well as vascular cover, because a pale pulseless hand means complete vascular occlusion of that limb. Okay. If you can get that child to a hospital, say within 2-3 hours, you just transfer the patient with splintage. But if you think it takes more than that, and if you think that even once a child comes to the tertiary center and you think it's going to take time, you might as well do a fasciotomy before you send the child to that hospital, and make sure you just don't fill the transfer form and send pack the child off and go. You call the receiving end, alert them that this child is coming, talk to the orthopedic team, talk to the vascular team before you send. At least keep them informed and tell them that the child's coming. Make sure the child is kept fasting. You don't want the child to be given malupang halfway down the line, because that happens. You tell the person who's accompanying the child nothing orally. Okay. The management depends on where you are, how far you are from tertiary center. If you can get if it's say half an hour away, transfer. Don't do anything, splint it and transfer. If you think the child it's going to take time for the child to get there, do a fasciotomy and send.
Okay, great. Thanks, Harsha. There are 3 more questions on compartment syndrome, which are not really related to this. There is one on external compartment syndrome due to tight plaster,
Sure.
etc. I think we will probably arrange a separate session and go into compartment.
Why don't we arrange a separate question, session on compartment syndrome?
Yeah, that's fine.
Okay.
Regarding supracondylar, the other relevant question I can find here is, you mentioned the timing of the fasciotomy just before, so I won't go into that. The other question is, when do we need open reduction?
So as I said, going up again, sorry, going down. Most of these fractures, we can get a good reduction closed without opening. What we do is we take the child to theater, we put them under anesthesia, and for those who've been to a theater, there's this device called the fluoroscope, or what is colloquially called a C-arm, which is basically an intraoperative X-ray device, where you can actually reduce the fracture under X-ray guidance. Okay, but sometimes these type 4 fractures over here, they are very unstable. So despite your best efforts, you cannot achieve a good reduction. In those cases, you have to go for, you're left with no other option but to go for an open reduction. Okay.
Great, thanks. I think, Harsha, that's all that we have related to supracondylar. The rest are about compartment syndrome.
Okay.
You explained when manipulation under anesthesia is indicated as well. So I'll skip this question also.
So basically, type 2 and beyond requires some form of manipulation.
Okay.
Type 1, just splintage, that's all. Okay.
Great.
All right.
Thanks, Harsha. Shall we then
move on to the next section?
Okay, thank you.
All right. Okay, clinical scenario number 2. You've got this 72-year-old male who's a diabetic on treatment and also a patient with ischemic heart disease. He's had a fall and he's unable to stand up and he complains of pain in his right groin. Now, unfortunately, he was alone at home when this happened and he had no option but to lie on the ground till his family members arrived several hours later. Okay. So besides this pain in the groin, he has no other complaints and the limb is shortened and externally rotated. Now the patient has fallen hours ago, was lying on the ground, has a painful groin area, can't get up, leg is shortened and externally rotated, and now he's wheeled into your emergency room. Now what could it be? So this is a classic presentation you see during any surgical casualty. All right. Okay. Such a history, such a patient, such a examination of a shortened external rotated limb is a hip fracture till proven otherwise. Okay. It could be a mid-shaft femur fracture, but then the pain will not be in the groin, it will be in the thigh. Okay. So a hip fracture can have a shortened and external rotated leg, sorry. But here, until proven otherwise, it's a hip fracture. Now you notice I use the word hip instead of neck of femur. So if you look at this picture, neck of femur suggests this yellow bit. That is your neck of femur. When you say hip, you're talking about this pink area, the head, the neck, the trochanteric region, and the hip, the region of the hip extends 5 centimeters below the lowermost part of the lesser trochanter. So this entire area is called the hip with regards to fractures of the proximal femur. So when you say fracture of a hip, you're talking about this part of the proximal femur. Okay, head, neck, trochanteric area, and this area 5 centimeters below the lesser trochanter. That is important. Okay, we'll talk about the importance of that a little later. So you have this patient. Now the patient's in the casualty. Now what do you do? Again, the 3 pillars of diagnosis and management. history examination, investigations, and then your management. Important things to ask is, why did this patient fall? It's a very important question which needs to be asked simply because, did this patient trip and fall? Did this patient slip and fall? Or did this patient have a disease spell? Did this patient have palpitations? Or did this patient skip a meal, take his his hypoglycemics and then fainted? So these are very important because those ones which have, they could signify a impending stroke or maybe a cardiac problem. So those are things that you have to ask. Why did the patient fall? The patient say, I tripped over my own slipper. So that's fine. Okay. Also remember, when the patient falls with the entire body. So you got to examine and inquire about possible injuries elsewhere, especially head injuries in elderly. Okay. Important to ask about comorbidities. Now this patient has had diabetes and ischemic heart disease. Now this is important when it comes to preparing this patient for surgery and optimizing this patient for surgery. You don't want somebody who is severely hyperglycemic to go in for surgery. You need to try to get it under control. And also medications like clopidogrel, warfarin, where there's going to be increased bleeding, is going to be problematic for the surgeon during surgery. Also, the chain of events from the moment of fall is very important. Now, if you just go back to this bit, he was found few hours on the ground. That's important because what happens is when a especially an old person lying on the ground immobile for hours on end, you have myonecrosis because of pressure, and myonecrosis can lead to acute kidney damage. So in this particular patient who's been lying on the ground for a long period of time, you've got to make sure that the renal function is up to scratch. You have to hydrate them properly. You've got to look for input output, and you got to monitor electrolytes and creatinine. So and do creatine for CPK levels to make sure that there's not much gross muscle damage. Okay. So, and also now you've taken the history and examination, and now you move on to your investigations. Your investigations are, number one, for diagnosis. So what do? You ask for X-ray pelvis AP. You don't ask for X-ray hip. You ask for X-ray pelvis AP. Okay. So what do you look for? Now, on this X-ray, you see, unfortunately, fracture. This white line, okay, is called the Shenton's line. Shenton's line is where the medial cortex of the femur, the cortex of the neck of femur, and the this margin of the obturator foramen all fall in a nice smooth curved line compared to the opposite side where that line is broken. So that is the classic sign you see on any hip fracture. If you see the Shenton lines broken, then of course you got a problem. You know that there is a fracture. Then of course there are these patients who have undisplaced fractures, maybe just a hairline crack. You can't see a fracture on the X-ray properly. You do the X-ray pelvis AP, patient complains of pain in the groin, leg is not that much rotated. What I do is ask the patient to do one thing. I ask the patient to do an active straight leg raise with the knee straight, to raise the leg straight up without bending the knee. If the patient is unable to do that, then automatically I think, all right, this patient may have an undisplaced fracture of the neck of the hip. So I need further imaging, namely a CT. But if the patient can do a straight leg raise without any problem, it's very unlikely the patient has a fracture. Okay. So you've done your investigations for diagnosis. Then you move on to investigations for fitness for surgery. You got to do a full blood count, more than full blood count. You basically want a hemoglobin level. You want to know what your electrolytes are doing. You need to know what your renal function is doing, your sugar levels, an ECG and a chest X-ray. These are old people. You got to do the baseline investigations. Since the patient has had ischemic heart disease, the anesthetist may request for you to do an echocardiography. Okay. So these are the investigations that you need to arrange before the patient goes in for surgery. Right. And also, as we'll discuss later, all hip fractures are managed surgically, and most of these surgical patients, before they go to theater, you need to have blood ready. So you need to at least send for 1 pint of blood to be cross-matched before the patient goes to surgery. So that's something that has to be done. Okay, so you've investigated, you've diagnosed, and you prep for surgery. Okay. Right. Now what to do? Now the patient is awaiting surgery. The patient does not straight go to theater. The patient has to be optimized and then go to surgery. Surgery has to happen ideally has to happen within 48 hours. Earlier the better, but the patient has to be optimized before the patient goes to surgery. Now you can't let a patient with a broken hip be in the ward without any form of immobilization. So what do you do now? The patient's there, you've done the investigations, you've done the x-ray. Now you got to offer the patient pain relief because hip fractures are very painful. So you can start on some analgesics. Now, in a person who's diabetic, elderly, who's been lying around with possible myonecrosis leading to renal problems, I will try to stay away from non-steroidal anti-inflammatories. I will stick to things like paracetamol and codeine, so-called Panadine. You can use things like tramadol. You may use some morphine or pethidine. Okay, so those are basically your pain management ladder with pharmacological management. The other thing that you do is to immobilize the hip. Now you can't put a plaster to immobilize the hip because you'll have to put it up to the thorax. So what you do in these patients, you apply skin traction. Now here is a picture of a limb with skin traction. Now this plaster which is used is called traction plaster. It is not your standard elastoplaster. This is available in wards. So you have to apply it from mid-thigh on the lateral aspect of the leg around the ankle, leaving a loop here and then go back up the leg. Okay. So you got to realize, you got to note when you put this on, all the bony prominences around the knee, medially and laterally, and bony prominences around the ankle, laterally and medially, have to be padded before this is put on. Otherwise, you're going to cause pressure damage on those bony prominences. Then on this loop, you attach some weight. So the maximum weight you can apply on skin traction is 10 pounds, not kilos, pounds. So you're looking at about 9 kilos. All right. Anything more than that, you're going to literally have skin traction. You're going to pull the skin straight off the patient. So 9 pounds is the most amount you can put. That amount reduces, especially in the elderly, because they have paper thin skin. If you put 9 pounds on paper thin skin, you're going to peel the skin right off. Okay, so in elderly, you want to dial the weight down. Okay, so analgesics to reduce pain, skin traction to keep the leg in alignment. That also reduces pain. Now also, you can ask your anesthetic colleagues to help with a fascia iliaca block, where you instill a fairly large volume of local anesthetic under the iliac fascia, which will then disperse and anesthetize that region. So that's actually very helpful, especially when you need to move the patient either for X-ray or to move the patient to theater. So a fascia iliaca block, you can Google it. The information how it's done or the details about that is available online. You can check that. So you've examined, you've taken history, you've investigated. Now you arrange for analgesics. Now you got to prep for surgery. Now you keep the patient fasting till the senior sees the patient. You start fluids. Remember, this particular patient is at a high risk of acute renal failure. So you start some fluids. You catheterize the patient because the poor patient can't move to pass urine because he's got a broken hip, and you got to consent the patient to surgery. Okay, and you got to inform the theater. and tell the theatre surgery within 48 hours is what is generally recommended. But of course, there are instances where the patient is not optimally optimized by 48 hours, may be delayed a little later than that. Okay. So this is what the job of the intern is. Examination, inquire as to what happened, chain of events. And if you don't tell your boss the patient is on clopid and the patient is operated on the same day, you're going to end up in trouble because there's going to be so much blood loss. There's going to be problems, and especially blood loss in a patient with ischemic heart disease is a recipe for disaster. Okay, so all this has to be documented, all do the investigations, pain relief, and all this stuff. Okay, right. Now, a little bit about hip fractures. Now, why are hip fractures so important? Why do we talk about it? Why, or at least why was it so important that we're discussing it today? Just imagine you break your hip. Just imagine the amount of loss of independence. You won't be able to do anything for yourself. All right. And a hip fracture is not just a fracture. Why I say this is a hip fracture causes immense physiological stress. Your blood sugar goes through the roof, your blood pressure goes up, all your catabolic, you go into a state of catabolism, and it's a huge stress on the body. So much so, despite best possible treatment in any part of the world, 30% mortality at 1 year. So 30% of all patients with hip fractures, elderly patients with hip fractures, are dead within 1 year, despite your best efforts. Okay, and that still is there's still a very high 30-day mortality rate. So you have to kind of mentally prepare not necessarily the patient, but the relative of this possible eventuality. Okay. And on the flip side, if you don't do anything for the fracture, the patient is going to die a horrible death, complicated by DVT, bed sores, infections, and this is not the way to die. So one of my mentors once told me, neck of femur fractures, hip fractures, always surgery. It's either heaven on earth or hell on earth. If you do it and the patient pulls through, it's heaven on earth for the patient. If you don't do it, it's going to be hell on earth for that patient. So always surgery, and you have to counsel the family members that surgery is important. Okay. So I just want to impart on you how important hip fractures are. Okay, anatomy, a little bit of anatomy, especially with regard to hip fractures. There are, from a management perspective, there are two types of categories where we divide the hip fractures into. So mainly depending on where the fracture line lies. If the fracture line lies within the capsule itself, they are called intracapsular fractures. And if the fracture line lies outside the capsule, you say it's an extracapsular fracture. Now, anteriorly on the femur, the capsule attaches to the intertrochanteric line anteriorly, and posteriorly on the neck, it's attached somewhere in the middle of the neck. So the importance of the capsule arrangement is that the blood vessels to the head of the femur runs along the neck of the femur, plastered by these reflected layers of the capsule. So if you have an intracapsular neck of femur fracture, these vessels get disrupted. Okay. So if you look at it, the head of the femur is supplied mainly by these what we call retinicular vessels, which are from the deep femoral artery through the circumflex anterior and posterior vessels, feeding your trochanteric and your cruciate anastomosis around the trochanteric region. And from here, you get these retinicular vessels feeding the head. You also have a nutrient artery coming from within the bone into the head. And you also have a very small component from your ligamentum teres, which is insignificant in adults. Okay. So when you have an intracapsular fracture, you lose these retinicular blood vessels, you lose your nutrient artery. So which leaves your femoral head avascular. So therefore, intracapsular neck of femur fractures have a high risk of avascular necrosis of the femoral head. Whereas extracapsular fractures, your intracapsular neck of femurs can be subcapital, meaning it's just at the base of your head, or mid-cervical, right at the base of your middle of your neck, or basicervical, where the fracture is just at the base of the femoral neck. So extracapsular ones are your intertrochanteric or your pertrochanteric fractures there, and your subtrochanteric. So your intracapsular neck of femur fractures have a high risk of avascular necrosis. Therefore, management tend towards replacing of the head rather than fixing it, because despite best fixation, this undergoes avascular necrosis and you're going to need a second procedure. Usually elderly patients, maybe after 55, you do a replacement. But if you get an intracapsular fracture in a young patient, say in a 35-year-old patient, you don't replace, you fix it. Simple reason, because even though there's a high risk of avascular necrosis, and you fix it and fails, you still have an opportunity to do a hip replacement later on. But if you do a hip replacement initially, you have to understand an artificial hip is never as good as the hip we are born with. So we give the femoral head a chance to survive in young patients, fix them, and if it fails, can't help, then we go for a replacement. But in adults, a well-done hip replacement lasts 20 years. So if a patient is, say, 60 years, you tend to go towards a replacement. Okay. But extracapsular fractures like these pertrochanteric fractures don't have a problem with avascular necrosis, and these fractures, your pertrochanterics and your subtrochanterics, are well managed with surgical fixation. So that's the important difference between intracapsular and extracapsular fractures. Intracapsular fractures, most of the time you replace. Extracapsular fractures, you always fix. Okay. Right, just some x-rays. So all of these fractures, note that the Shenton's line is now broken here. So here you have a nice Shenton's line on the left side, whereas the Shenton's line on the lateral side is just gone. Okay, so this is obviously a intracapsular fracture. This looks mainly like a basicervical fracture to me. Sorry, it looks like a subcapital fracture to me. This one is extracapsular. It looks between the trochanter. So this is an intertrochanteric fracture. This one is classically a subtrochanteric fracture. Okay, so this needs to be replaced. These can be fixed. Okay, right. Just a little bit. Management of hip fractures, always surgical. Now, the first one is usually done for intracapsular fractures in young patients. So in young patients, you don't want to replace immediately. You want to see if you can fix this and preserve the head. If it works, fantastic. If it fails, you have plan B, which is a hip replacement. So this type of fracture, fixation with parallel implant screws to fix an undisplaced or a intracapsular neck of femur fracture in a young person, is fixed with screws. Now this is an intertrochanteric fracture which you can see, which is fixed by a device called a sliding hip screw, which is commonly called a dynamic hip screw, or a DHS. So this device is quite commonly used to fix this type of intertrochanteric fractures. This plate is placed outside the bone, so it's extramedullary. But this screw goes into the femoral neck, into the head. This device, on the other hand, is intramedullary. So this nail is inside the bone, and this screw goes from the outside of the femur through this nail into the femoral neck. So this is a intramedullary nail. All right, so these are methods of fixation. These two are methods of replacement. Now look at this. This one, you have this stem. Both have stems into the femoral canal. Both have necks. Both have a circular ball. But this one also has a separate cup. This cup sits in the acetabulum. So what's happened here? We've not only replaced the femoral head, we've also replaced the acetabulum as well. So this is a total hip arthroplasty or a total hip replacement. Here, we've just replaced the ball, we've just replaced the femoral head, and we've not touched the acetabulum. So this is a half hip replacement and therefore called a hemiarthroplasty. The difference between this, where you do this versus this, is depending on the patient's activity level. If irrespective of the patient's age, if the patient is very active, even a patient in their 70s who are driving, who are very mobile, who are very independent, best to do a total hip replacement where the patient has the best mobility. But if the patient is just a very person who has been walking previously with a walker, generally ambulates from the chair to bed, and that kind of person, you go for, with less degree of activity, you go for a half hemiarthroplasty. This is generally a quicker surgery. It's less traumatic and less expensive. This is more expensive, more technically demanding, and it is a long, technically a difficult procedure compared to this side, this one. So that is the difference between these two. So again, extracapsular fractures are amenable to fixation as we see in these two. Intracapsular fractures mainly managed with replacement. Mainly. When I say mainly, young patients, 20s, 30s, you want to see if you can fix it like this to preserve the head. If you manage to do it, well done. If you don't, then you have plan B. Okay, so that's why I said mainly managed, intracapsular mainly managed with replacement, because as we discussed, due to the risk of avascular necrosis. Okay, now you've done all that, you fixed all that, but there are still some considerations to make. Now, again, you have to do a fall risk assessment before the patient goes home. You have to find out whether the patient will fall again and undo all your good work. So you've got to check whether the patient has any of these problems: arrhythmias, postural hypotension, hypoglycemia, visual problems. Really, with elderly, visual problems can cause a lot of falls. Okay, vertigo, and you have to ask about the home environment. Are there lots of steps? Are there lots of little babies with toys lying around? Those things you got to ask. Okay, and finally, you got to think about the place for bisphosphonates. Bisphosphonates are basically your alendronate things for your, so neck of hip fractures are osteoporotic fractures. Are you going to start bisphosphonates early? Right. Now, bisphosphonates act against your osteoclasts. Now, when you have a fracture which is fixed, you require your osteoclasts for remodeling of the bone. So if you give things like alendronate in these patients, there will not be a proper remodeling process happening. So this is actually going to fail. So in this kind of patient who have fractures fixed, you want to delay your bisphosphonates. But on the other hand, these kind of things, there's nothing to fix. There's nothing to heal. In this kind of patient, you can think about starting bisphosphonates early. I hope that's clear. Yep, that's about it for hip fractures.
Great. Thanks, Harsha. Again, we have lots of questions.
Oh boy, here we go.
Yeah. So we'll start with, why should we avoid NSAIDs in hip fractures?
All right. So I'm talking about this particular patient. This patient is a diabetic for a long time. So you know diabetes causes small vessel damage, and one of the places where diabetes affects is the kidney. All right. And on top of that, this patient has been lying on the ground for a long time. You get myonecrosis due to pressure lying in one place. Therefore, you get myoglobinuria, and that too can affect kidneys. Now, these are elderly patients. Now, remember, your renal reserves tend to go down with age. You have advanced stage which reduces your renal, the amount of the functional capacity of the kidneys is already compromised purely by his advanced stage. You have a patient who's diabetic, so his renal function is going to be further compromised. And furthermore, he may have myoglobinuria, which is going to further knock off his kidneys. And he's got 3 strikes on his kidneys already. Are you going to throw in a 4th one? So you got to be a little bit more cognitive when you manage the pain. So things like paracetamol with codeine, tramadol, fascial blocks are available for you. So that's why I tend to avoid patients. And also this patient is going in for surgery where there could be hypovolemia, and that also is going to kill your kidneys. So you have to protect your kidneys. You have to protect all the other organs. No point fixing the femur and cooking the kidneys. So that's the reason why I tend not to use NSAIDs.
Great, thanks. Next question is, can we use skeletal traction instead of skin traction?
Well, yes, you can, but you don't do it. It's like saying, can you use cow dung to treat dengue? You can, but it's not going to help. Remember, skeletal traction is very um, invasive. You require an anesthetic to do that. You are drilling a big pin through your distal femur to apply traction. You can apply traction to a distal femoral pin, correct? But it's not the smart thing to do. You can do it, but you should not do it because that requires a further surgery where you can just put some skin traction that can be done in the ward relatively painlessly without any form of anesthesia.
Okay. Next question is, do we have to take measures to prevent DVT in the preoperative period in hip fractures?
Good question. If you foresee the surgery to be delayed due to some reason, if the patient has if the patient's been on warfarin, okay, or sorry, if the patient's cardiac condition is at the moment not amenable for any surgical intervention, or the patient is not suitable for anesthesia immediately, yes, of course, you can start on something like enoxaparin, a prophylactic dose prior to the patient going for surgery. So usually you give something according to body weight, a single dose. I time it. If we see that the patient is going to get delayed to go to theater, say maybe 48 hours, then yes, you start enoxaparin, and on the opposite leg you can put some stockings. Of course, I give the enoxaparin at about 12 noon. So the next morning, by the next morning, the effect of that will be gone, and I'll be safe to operate the next morning. Yes, so that's a good question.
What are the causes of death in patients with hip fractures?
All right. So right off the bat, the hip fracture alone won't kill you. Okay. Then we go back to the assessment. Did the patient have arrhythmias causing the fall? So a pre-existing cardiac condition can kill you. Okay. Poorly managed diabetes can kill you. A stroke can kill you. An MI can kill you. On top of that, DVT leading to a large pulmonary embolism can kill you. Delayed, either non-operative management has been taken, patient develops a benzo and sepsis, patient can die. Urosepsis, respiratory sepsis is a killer, especially in the elderly patients. When they are lying flat, you get atelectasis, and then those patients are at high risk to develop chest infections. So infections, DVT, and pre-existing medical conditions are the main killers in hip fractures.
Thanks. Then two questions on intramedullary nail versus DHS. When do we use them, and is intramedullary nail superior?
I would say intramedullary nails are superior. They offer more mechanical support. They can be inserted through small incisions, and you can get the patient weight bearing a little more early. And of course, a dynamic hip screw cannot be used in subtrochanteric fractures. So if it's a subtrochanteric fracture, you have to use an intramedullary device, not a extramedullary plate like a sliding hip screw. So mechanically, the intramedullary nail is what we call a load sharing device. It shares the load. Whereas the extramedullary plate, the sliding hip screw, is a load bearing device where it takes all the weight. So you prefer to have something more mechanically sound like an intramedullary device. Yes, they are far superior, but a little more technically demanding.
in a young patient who has had a failed fixation, I assume they mean fixation.
Yeah, intracapsular.
Or an
Intracapsular, yeah.
Do you always go for a total hip replacement?
Absolutely. Because young patients, you are you are going, they'll be active. Okay, they'll be active. Unlike an elderly person, a total hip replacement gives much better functional recovery rather than a hemiarthroplasty. And with the more recent, well, not I wouldn't say recent, with more advanced materials, now we've got ceramic hips which last fairly long, and they can last up to about 30 years if done properly, and they give really good results. So definitely young patients, you require a total hip replacement, not a half hip replacement.
Thanks. Then what is the management of undisplaced neck of femur fractures?
Still, it has to be fixed. Remember your hip is a place where a huge amount of stress goes through. If it's undisplaced, it still needs to be fixed. It's that simple. Because you wake up in the morning, you don't know what your leg's been up to during your night. You kick somebody in your sleep, by the morning it gets displaced. And it's actually easier to fix an undisplaced fracture rather than a displaced fracture. So an undisplaced fracture also requires surgery. Full stop.
Next question. If the patient is elderly and if the fracture is non-displaced and intracapsular, can we use cannulated screws or should we do a replacement?
That's a very good question. Now, you can do cannulates, you can do screw fixation in that setting. Okay. Now you should think in a different way. Now, what if this fails? Is this patient fit enough for a second surgical procedure? You'll find out whether your fixation fails few months down the line. If the patient if the patient is in their 80s, are you going to take the, anyway you're going to the theater, anyway you're giving anesthetic, anyway you're going to do a fixation. Why are you going to do something which may require a revision later on with no added benefit? So I'd rather have one surgery to end it all rather than a possible second surgery to salvage the first one. And you're dealing with a patient who's had a hip fracture with multiple comorbidities who may not be physically fit to undergo second procedure 3 months down the line. In such patients, I will always replace.
Okay, great.
I hope that makes sense.
Thanks, Harsha. Next question is, could you mention the indications for total hip replacement? Sorry, the question is, I think the wording of the question is a bit off, but the question is, isn't total hip replacement when there is a fracture in the acetabulum?
No, absolutely not. A fracture acetabulum is managed with open reduction. If it's a displaced fracture acetabulum, the management is open reduction and internal fixation. Okay. But of course, there are some fractures in the acetabulum where everything is blown to smithereens, where you cannot actually go and fix things because the pieces are so small, you can't go and fix them. So in that kind of setting, of course, what you do is you place the patient in traction, let the fracture heal, let the fracture heal, and later on let it remodel, and then go for a hip replacement. You do not go for a hip replacement in the acute setting of a acetabular fracture. Acetabular fractures are predominantly managed with open reduction and internal fixation if it's displaced. If it's not displaced, you can manage it with traction. Okay. So a hip replacement is not the answer for acetabular fracture.
The next question on how does degree of displacement affect the management of the fracture? I think
not at all. Does not cause. It's not of any concern at all. It's always surgical.
Next question: what's the duration for which a total hip replacement can last before we go for another one?
Generally, what we tell the patient is it tends to last for about 20 years. Done well, it lasts about 20 years. But there are hip replacements done in the 60s which are still doing well today. So sometimes hips fail due to unforeseen reason. For example, if the patient has poor quality bone stock, then it could fail earlier. So it's really a question of how long is a piece of string. You don't know, but generally it tends to last for about 20 years, a total hip replacement.
Okay, great. Then again, undisplaced fracture has been asked. Does the decision of hemiarthroplasty over total hip replacement only depend on the level of activity of the patient?
Absolutely. Well, in an ideal setting, yes. That is the only consideration where you differentiate whether you are doing a total hip replacement versus a hemiarthroplasty. Unfortunately, we live in a third world poor country where I'll just put things in perspective. A basic hemiarthroplasty is about 10,000 rupees. Austin Moore hemiprosthesis is about 10,000 bucks, whereas a total hip replacement will be about 300,000 rupees. So you are looking at about a really big difference in price. Sometimes there is a trade-off, but if you're answering a question, a medical question, the answer would be the only consideration is the level of activity. But unfortunately, living in a country like ours, we might have to make some concessions price-wise. But don't say that at the exam.
Okay, next question. Any contraindications for total hip replacement in a young patient? You answered that, I think.
The only contraindication for hip replacement is, are you talking about in the presence of a hip fracture?
I believe so, isn't it? I think we are talking about intracapsular probably.
Yeah. So I mean, no, there is only contraindication if the patient does not want to.
Okay. Can the patient move like before, after a total hip replacement?
Sorry, didn't get you.
Can the patient move like before, after
Absolutely.
hip replacement?
They will. You will not. If a total hip replacement is done properly, you will not be able to tell the difference between a normal person and a person with a total hip replacement.
Okay, great. Then if a sportsman gets a neck of femur fracture, what is the management?
I'm assuming that you're talking about intracapsular neck of femur.
Probably, isn't it?
All right. So when you're seeing a sportsman, we're looking at a young person. Okay. So in a younger person, as we said, we try to preserve the femoral head even though it's an intracapsular neck of femur. We fix it with screws. If it fails, of course, then we go for a total hip replacement. Unfortunately, that could be career end. If it's a rugby player, he will not play. End of story. Of course, if the sportsman is a chess player, no problem.
Depends on the sport. When to mobilize patients after these surgeries?
Absolutely. So again, total hip replacement, hemiarthroplasty, weight bearing, full weight bearing immediately post-operatively. Intracapsular neck of femur, if it's a two-part fracture, almost immediately you can go for full weight bearing. But again, the surgeon has to decide on table. I always direct my physiotherapist. I say, all right, this particular patient, there's quite a lot of comminution. I will go for just partial weight bearing initially, and then maybe after 4 weeks we can go full weight bearing. But if I find after fixation I feel that it's solid, full weight bearing immediately.
Okay.
I tell the patients technically they can walk off the table.
Perfect. Okay, I think we fielded all the relevant questions up to now. Shall we move on to the third part?
Yeah, sure. Okay, perfect. Right. Third scenario, you've got a 27-year-old, previously well male, as they all do, falls from a motorbike. And this is his leg. He presents with pain, deformity, and a wound in his right leg. Okay. He's got no other complaints. And you can see the end of his bone coming to say hello right there. And you can see some, plant material and some ground material on the wound. The rest of the examination, the neck, the back, the hips, everything else is normal. All right. So it's obvious what the problem is. Okay. So what's the problem? Is the patient's got an open fracture of the right tibia and fibula. Now, if you look at this, if you really conceptually look at an open fracture, it is, if you look at it, it is an incomplete traumatic amputation of that part of the limb. The bone's broken, some or most of the soft tissues is gone. All you got to do is a little bit of snipping and you end up with a complete amputation. So it is not something you take lightly. And very importantly, if left untreated, open fractures of main long bones are necessarily fatal. Let that sink in. If left untreated, open fractures of your main long bones are necessarily fatal. So much so, long time ago, open fractures were managed by surgeons using amputations. You just cut the part off because they didn't have antibiotics, they didn't have anything else. So they just amputate the leg and hope for the best. If they don't amputate, you can bet your bottom dollar the patient is going to die. So that is how serious open fractures are. So don't take them lightly. Okay? And even in today's day and age, if you improperly manage them, you end up with a lot of morbidity, long-term morbidity, mainly with malalignment, malunion, and mainly infections. Because let's face it, infection, the difference between an open fracture and a closed fracture is the problem of infection. So infections in these are really problematic and they have to be dealt with promptly. Okay. Now here's this patient, lovely looking leg, in front of you on a trolley in your surgical casualty. Remember, he's come off a motorbike. It's not just his leg which came off which came off the motorbike. The rest of him came. So there is likelihood, even though I say the rest of the examination is normal. Now remember, I said the rest of the examination is normal because this is a very common scenario which gets asked at your viva. And if the examiner says rest of the examination is normal, please don't bother by saying I will go to A, B, C and all that. You say, since there is no other abnormal findings, I will concentrate on management of the open fracture alone, and then you say what you have to say. But unfortunately, you're not in the exam setting, you're in the setting of in a ward. So patient comes to you with this, you got to examine the limb, you got to examine the rest of the patient. Okay, you examine the rest of the patient and you find out that there's nothing else wrong and you examine the limb. Is the vasculature okay? Is the neurology okay? Is there compartment syndrome? We discussed that earlier. Okay, even though this is a different limb, you got to examine those. Now, you've done that. You have this in front of you. What do? Right. Now, there is visible muck in the wound. So what you do is you decontaminate the wound. The word is decontaminate. You don't do a wound toilet in the ward. You do a gross decontamination. You can't take everything out, but you can take the big pieces that you can see. Okay? You gently place the leg over a basin and you just irrigate the wound with sterile saline. Not distilled water, not tap water, saline. Okay, because remember tap water is hypotonic and that can also cause tissue damage. And of course, do not try to poke the bone back inside the leg. If the bone is sticking out, you leave it like that. You're not going to put it back in. That's not your thing to do. Next thing you do, which seems quite brutal, is you photograph the wound. You don't need a digital SLR with a big wide aperture lens. You can use your mobile phone. Take a photograph of the limb. Why? Because you are an intern. You are somebody who will not be making decisions, but the people who will be making the decisions will have to see what the wound looks like. So next time the SHO, the registrar, the senior registrar comes, you can't be taking down the dressing to show what the wound looks like. So you say, all right, nothing doing. The dressing stays on. Here is the wound. Okay. And remember, when you take a photograph of the wound, take a ruler and place it by the side of the wound for scale. So you can so the person looking at the photo will be able to gauge the size of the wound because you have a reference scale by the side of it. Okay. Now you've taken your photograph. Next, most important thing you do, and I want to underline the importance of this, you cover the wound with a sterile dressing. I know it sounds like a very stupid or a very basic thing to say, but this is one of the most important things that you do immediately, as soon as possible. And the reason for that is now the patient is in the ward. You're not worried about roadside infections. You're worried about hospital-acquired infections. So you try to close the wound with a sterile dressing as soon as possible. Okay. The next thing you do, you start intravenous antibiotics. Not oral, you start intravenous. Okay. Again, depending on the level of contamination, if it's uncontaminated, all you need is a second generation cephalosporin, something like cefuroxime, usually a double dose for the body weight. If there's some sort of, if you think it's a little bit contaminated, you can add an aminoglycoside like gentamicin, a daily dose. But of course, if you see soil, if you see grass inside, you need to cover for anaerobes as well. Then that means you need to have something like metronidazole as well. Okay. The next infection that you got to worry about is tetanus. If the patient, ask the patient whether the patient has received a tetanus toxoid within the last 5 years. If the patient has had a tetanus shot in the last 5 years, you can let it go. But if he says no, you got to make sure the patient gets a booster dose of tetanus. Okay. Then after that, you splint the leg. You give some analgesics. Again, your analgesic ladder. You order your X-rays. You order your X-rays. In this case, you ask for X-ray tibia AP lateral. Remember, you got to see the joint below the bone, below the fracture, your ankle joint as well as your knee joint. And while the patient is on the way to the X-ray, you inform your seniors, say there is a patient with what appears to be an open fracture of the tibia and fibula. Okay, so you have to inform them and inform the theater that such a patient will be coming in. All right. Now, the question arises, when does the patient, now the open fractures, all of them go to theater. Every single one goes to theater. Question is, when does the patient go to theater? The patient goes to theater on the next available list. Understand that concept. If the patient comes at 2 o'clock in the morning, the patient does not go to theater at 2 o'clock in the morning. Those days they talked about a 6-hour grace period. If the patient has to go to theater within 6 hours, that has been proven unequivocally as not true. If the patient goes to theater in the middle of the night, the theater staff will be fatigued. The surgeon who goes in will be not the most experienced one. He'll be fatigued, and also in Sri Lankan setting, you won't have enough saline, you won't have enough towels, you won't have enough gauze, because all that would have been exhausted during the day. So the patient goes to theater in the next available list. Who does the surgery? Not the least experienced. It's actually an open fracture of a long bone has to be managed by someone with considerable amount of experience. This is no joke. Okay. It is not something that is to be delegated to the intern. It has to be at least an experienced senior house officer who does it. Right. Now the patient, you've done all this, you've examined, you've decontaminated, you've photographed, you've covered, you've given antibiotics, you've given toxoid, you've splintered, you've given analgesia, you got the X-ray. Now the patient is going to the theater. What happens in the theater? Patient is under anesthesia, the leg is cleaned. Now there are three main things that need to be done. You've got a contaminated leg. You got a potentially dirty leg wound. Now you got to convert this dirty wound into a clean wound. So what we do is called a wound debridement, or what some people call a wound toilet. The proper word is wound debridement. And it's a French word. Some people pronounce it as débridement because it's French. French people are funny. So what do you try to do in a wound? What do you do in a wound debridement? Most importantly, all contaminants are removed. All contaminants, not even a little speck is left behind. Therefore, a proper wound debridement takes at least 1 hour. At least. In my hands, I take at least 1.5 hours to do a proper cleaning. So let that sink in. It is not a 5-minute job. You just don't put some saline and don't do this and come out. It is at least a 1 hour job. So all contaminants are removed. All dead tissue is excised, and you go from skin to fat to fascia to muscle to bone. To the entire depth of the wound, you have to take out all dead and devitalized tissue. Okay? If the skin around the wound is contused, you take that out. All raggedy edges of the fascia is taken out. All loose fat is taken out. Then you come to your muscle. If the muscle is visibly dead, if it does not contract to stimulation, that muscle comes out. If it is 50-50, you leave it, you come back later to have a look. Importantly, all bone pieces with no soft tissue attachments or free-floating bone pieces are taken out. There is no question about that. Any free-floating bone pieces, big, small, comes out. Only exception where the bone piece does not come out is if that piece of bone is a part of a joint. If that piece of bone forms a part of the knee or the ankle joint, only that piece, even though it is divided, removed from all soft tissues, is preserved. All the others are taken out, even if it's a big bone piece. We can deal with bone loss later on, but dead and devitalized tissue, everything comes out. Okay, so you've done that. You've all dead and devitalized tissues taken out. Now you get to the ends of the bone. The bone ends have to be brought out of the wound, and the inside of the bone canal, the medullary canal, has to be curated. Because remember, bone spike can come out through the skin, get into the soil like a shovel, take a big scoop of soil into the canal, and then quickly go back inside your leg. If you just clean the outside of the bone, you can have a big dollop of soil inside the medullary cavity, which can lead to devastating infection later. So the medullary cavity has to be curated meticulously. And after all that is done, you have to wash thoroughly with a minimum of 3 liters of saline. 3 liters, not 3 pints, minimum of 3 liters. There's a saying that the solution to pollution is dilution. So you got to wash, wash, and wash. So once you've done all this, you can say you've done a proper wound debridement. And once a proper wound debridement is done, then you think about stabilizing the fracture. You can go for internal fixation if the contamination is minimal and you've got good soft tissue cover. You can go for internal fixation. But if there's a lot of contamination and you don't think that you've managed to do a proper job at the first setting, you have to go for an external fixation to stabilize the fracture. Okay, so you've done that. You've done the stabilization. Now, sometimes you need to get soft tissue cover for the wound. That may be a simple primary suturing, but it may require advanced flaps to be done, either a skin flap or maybe a myocutaneous flap or a muscle flap, or even a free flap where you might need the help from your plastic surgical colleagues. So these things are the main things: debridement, stabilization, soft tissue cover. Those are the 3 main things that need to be done in the theater. Okay, so that's all done. One thing that you're going to get asked at the examination with regards to an open fracture is a classification system. Now, this is one of the many classification systems, and this is probably one of the more easier and more universally accepted classification system for a open fracture. It's the so-called the Gustilo-Anderson classification. It goes from type 1 to type 3. Type 1 is the least amount of damage, where as you go down, the damage becomes more. The soft tissue injury becomes worse when you go down. The amount of comminution goes up when you go down. The amount of energy goes up when you go down. So type 1 would be the least problematic. whereas a type C, type B would be, type 3 would be more problematic. So type 1 is a wound less than 1 centimeter, low energy, no minimum soft tissue with no contamination. Type 2 is more than 1 centimeter with moderate soft tissue injury, and there is some contamination. Type 3 are generally large wounds, extensive soft tissue injuries, contamination, but you're still able to get acceptable soft tissue coverage with the available tissues. Type 3B is where it requires a flap coverage to cover the soft tissue deficit, and type 3C are the ones which require any fracture, irrespective of the size of wound, which require an arterial repair to salvage the limb. Okay, so if there's an arterial injury which requires repair, that automatically becomes a Gastido 3C, irrespective of the size of the wound. Maybe a gunshot injury with just a small penetration. If there is a arterial injury, it automatically becomes a 3C. So just go through this. This is available. This is common knowledge. It's available on the internet. So this is something you should know. And this is something that you might be asked at a Viva. Alrighty.
Okay, thank you, Harsha. Again, going to questions. Before we go up to that, there was one question from the previous set which came later.
Yeah.
On hip fracture. Is there any difference in clinical presentation between intracapsular and extracapsular fractures?
Sorry, didn't get that.
Is there any difference in clinical presentation between intra and extracapsular?
Well, yes. In intracapsular fracture, the degree of shortening and the degree of external rotation is less. I wouldn't say it's absent in intracapsular, but it tends to be less. But it really is, again, it's not something which is important. You're not going to diagnose intracapsular, extracapsular clinically. That is a diagnosis made on X-ray. So it really does not bear much of, it's not too important to try to diagnose internal versus intracapsular versus extracapsular clinically. It's pointless.
Great, thanks. Could you please tell us how to immobilize a patient with an open fracture who met with an RTA until transfer to a hospital, that is before ambulance?
Okay, so in this patient, so principles of that you hark back to the principles of immobilizing a joint. So you've got to immobilize the joint above and below the fracture. So in this case, you got to immobilize the ankle joint as well as the knee joint. So you need to have a splint which spans the ankle and the knee joint. If you're in a hospital, you can use plaster of Paris as a posterior splint. But if the fracture is an open fracture of the femur, you can't put a back slab, you can't put a splint, because again, you've got to immobilize the hip. You can't immobilize the hip with a splint. You can, but it's going to be very cumbersome. In the case of a femoral fracture, you can apply skin traction, like what we did for a hip fracture. There is a device called a Thomas's splint. It is a fairly old technology which may be available in your hospital. It's named after a person called Hugh Owen Thomas who lived several centuries ago. He devised this device which you put over the limb where you can exert counter traction with the limb. So if you Google Thomas's splint or a T-splint, you will see exactly what I'm talking about. If your hospital has a T-splint for a femur fracture, that's actually ideal before you transfer.
If there was heavy contamination, don't we need immediate surgery?
No. Again, that's why I talked about of decontamination in the ward setting. If the patient comes to you at say 6 p.m., of course, if the theater is available till about midnight, of course, that patient should go to theater. There's no question about that. But if the patient comes at 2 in the morning and you got to wake up the entire crew to get that case done in the middle of the night, the chances are you're going to get a suboptimal job done. Okay? But most important thing in management of infections in an acute setting is the proper choice and administration of the antibiotic. That is the most important thing. The immediate antibiotic is the most important thing when it comes to infection. Of course, the later surgical debridement is very important, but the most important thing in the acute setting is the antibiotic. So you wait for the next available list. You don't do this kind of thing in the middle of the night. When I say middle of the night, 2, 3 in the morning. But that was what was done before. But the evidence is now not supporting that kind of thing.
Okay. Great, thanks. Next question is, what should be done to the place where the skin flap is taken? Do we close it with suturing? I think we are talking.
All right. Okay. So the question is, there is something called a reconstruction ladder for soft tissue defects. Okay. So the reconstruction ladder, like your pain ladder, is the least thing you can, the least technical thing you can do is go for a primary suturing. Then you have options for secondary suturing, which is not an option here. Then you've got your flaps. You can have a muscle flap where you cover the bone with a muscle flap. In a flap like this, you might need a soleus flap to cover the lower end of the tibia. Once you've done that, you have exposed muscle. So what you do to cover that is you can have a split skin. You got a split skin graft on the muscle flap. If you have to take a myocutaneous, flap, the area which the flap was taken again can be covered with a split skin graft. Okay, so that, yes, so where the original graft was taken, you can manage with a split skin graft like you do for your other granulating wounds. So was that clear? What to do with the area you take the graft from, or your flap from?
Okay. Harsha,
Yeah.
you are, since I logged in again, I think the last few questions I would have missed on the chat because it's reloading now.
Okay.
I think the question I had lined up next was someone had asked whether tetanus immunoglobulin is...
No. Immunoglobulin is not, you just need a toxoid. You don't need immunoglobulins because you're not dealing with established tetanus. You just need to give the toxoid. No.
Yeah, from that point onwards, I think I missed about 3 or 4 questions. Do you think that you could go through them from your end on the chat?
Yeah, 1 second. Okay, so let's go on. Okay, tetanus. Hang on. Yeah. Okay. Next question. What should be done? Place where the skin flap is taken.
Yeah.
Okay. So if the skin flap, the region of where the skin flap was taken can be sutured, you can suture it. If not, you can have a split skin graft. Okay. So the next question. Soft tissue cover is the same surgery. Okay. Soft tissue. So soft tissue coverage is ideally done at the same sitting. You don't do the wound debridement and then you don't stabilize it and then you send the patient somewhere else. Ideally, you need a team. These are multidisciplinary. Now, gone are the days where it was a one-man show. It is now a multidisciplinary team effort. So in such cases, we liaise with our plastic surgical counterparts. I usually do my basic flaps by myself, but if I think I need a complex flap or a free flap, I definitely will get my plastic surgical colleague on board. Okay, so it should be done in one setting. Okay, so next, so what is the management compartment syndrome of reinforced? Okay, wait, I've gone backwards. Sorry. Okay. Usually, how long does it take to remove the internal external fixators? So you got to understand, internal fixator or internal fixation is meant to fix the fracture. They don't need to be taken out. External fixator is done as a procedure to help manage a soft tissue injury. Once the soft tissue injury is so the question was, usually how long does it take to remove the internal or external fixators after weight bearing is done? So first of all, internal fixation, generally a nail does not need to be taken out. External fixators are not aimed at fixing fractures. An external fixator is a temporary device we use to help manage soft tissue injury. Once we manage a soft tissue injury, the external fixator comes off, and then we think about doing a proper internal fixation later. Okay, is that understood? Okay. Next question is, could you discuss how we decide between internal and external fixation? Okay. If the question is, how do you decide between an internal fixation and external fixation? Internal fixation is done when you have minimum contamination, where you can confidently say, I have done a complete cleansing of the wound. You can go for an internal fixation. And if there is adequate soft tissue cover once the fixation is done, you can go for internal fixation. If you have neither, if you're not sure about the cleansing, and if you're not sure about the soft tissue covering, that is where you go for a temporary external fixator while you sort those two out. Is that clear?
Harsha,
Yeah.
if I may, another question I think might be important then clinically related to that is, in some cases without internal or external fixation, we see patients on POP casts with a window cut for the area of the wound.
Very good question. Very good question. So the question is, can you manage this patient with a soft tissue injury with an external splint? The answer, easy, no. That was done years ago because we did not have any of these. So the idea here is to manage a soft tissue, and you manage the soft tissues while you provide stability. A plaster does nothing. Every time you go for dressing, you take everything down and the stability is lost. So there is no place in the current practice, there's no place for plasters with windows cut. That not in this day and age, no. Is that clear?
Great, thanks for clearing that up.
Okay, so how does the management differ in intra-articular open fractures? That's a very good question. Intra-articular open fractures versus extra-articular. For example, a fractured tibial fracture. That's a very good question. Okay, so you got two separate problems on your hand. The principles of management of an open fracture remain the same. So what we've discussed up to now is the same. The second problem is management of an intra-articular fracture. So you have to tackle these two problems simultaneously. So here, the principles of management of a intra-articular fracture is open reduction, internal fixation, nothing else. Right. Okay. Now, what I would do, I would go according to what I said: debridement, stabilization, soft tissue cover. Because you're not going to do an internal fixation without a proper decontaminate, proper cleansing, and without proper soft tissue cover. Okay. And remember, you're not going to do an internal fixation through an incision where the skin and the soft tissues are all edematous. So I will do exactly what we said, do a proper debridement. I will go for an external fixator, which bridges the knee, okay, stabilize the skeleton temporarily with the external fixator, do a closure, soft tissue closure, and then the next day I will go get a CT scan of the knee joint. I will then be able to have a three-dimensional picture of what the fracture looks like. I will not go to fix the fracture in the immediate setting because the soft tissues will not be amenable to a proper internal fixation. Once we've got the CT, you know the morphology of the fracture, I will wait for the swelling to go down around the knee joint. that can take maybe 10 days to 2 weeks. That is okay. As long as the fracture is immobilized, is stabilized with the external fixator, that is fine. And once the swelling subsides, once we know that there is no infection, active infection, then we can go for a proper internal fixation of the tibial plateau. So we've got two clinical problems, two completely different clinical problems coming at the same time, but we cannot violate principles. So the principles of management of open fracture are the same. We do that in this patient, and management of an intra-articular fracture will remain the same in any patient. So you do that, but the difference is timing. You can't do an acute fixation because of the soft tissue problems. So you do an internal fixation later on, once you're certain that there is no infection, and once the soft tissue around the knee has improved or is now favorable for internal fixation. Is that clear?
I think we are almost up to 10.
Yes.
So I think one or two questions that I have at my end would have straightforward answers. If a patient presents with heavy vascular damage and bleeding, should he be taken to theatre immediately? I think.
Yeah, of course. I mean, that's the acutely vascular compromised limb, so it has to be repaired. That of course, remember, if there is a acute vascular injury, you have to stay. There is no place for plasters. It has to be, the fracture has to be stabilized with a fixator of some sort. No room for that. Has to be done immediately. That can't wait for the next day.
Okay. So again, one person has asked about Gastilow 3C fractures. So again, we have the same thing, isn't it?
Same thing, yeah.
Because
those are emergencies. Those have to go in.
Yeah. Then if the size of the soft tissue loss is more than 10 centimeters, what is the best method of tissue coverage? Again, I think it's the ladder that you talked about.
Again, it's a ladder. Again, soft tissue can mean, I mean, if you have adequate muscle cover, that's enough. It's not necessarily skin. You just need to cover tendon, bone, muscle. Sorry, you need to cover bone, tendon, vessel, and nerve with muscle. It need not be skin. You need muscle cover. You need vascularized tissue covering those structures, not necessarily skin. Okay. So again, your ladder.
At my end, Harsha, I think we have covered most of the questions. I will ask the students whose questions were missed to all of them are in the surgery WhatsApp group. So if any questions are missed here, please post them in the WhatsApp group. We'll try to get them answered by Dr. Harsha later on. So let's see whether there is. Right. So great. Lots of positive feedback messages coming in right now. They want more sessions arranged, etc.
Okay, that'll be great.
To that, if Harsha has time in the future.
Of course.
We have come up to 2 hours.
Yeah.
Let's call it wraps then.
Absolutely.
So I'd like to thank Dr. Harsha Ariyarathne for a very informative and interactive class. I think all of us enjoyed it a lot, learned a lot from it, and hopefully we can have a couple of more sessions, time permitting, in the future.
It will be my pleasure.
And I'd also like to thank the TRC, Mr. Vasanta Veerasurya, who's been brilliant at coordinating this and offering technical support. And the committee from PeMSAA who coordinates this, including Dr. Dumindi Asaratne and also Prof. Kudagammana, whose initiative the lectures were. So good night, everyone then. And thank you again, Harsha. Hope to see you with the next class sometime in the future.
Alrighty. Okay. Thanks.